Welcome to Get Briefed Podcast, the latest MDBriefCase group offering developed to inform healthcare practitioners regarding a variety of relevant medical topics. This podcast is available at www.mdbriefcase.com. The views, information, and opinions expressed in this podcast are solely those of the individuals involved and do not represent those of MDBriefCase. This podcast does not constitute medical advice and is only meant to educate and inform the listener. Please enjoy.
I'm Dawn Rae Downton. All you family physicians out there, have you got assessing pain under control and don't really need to know much more about it? Or have you been feeling, like so many of your colleagues over the last few years, that Canada's approach to evaluating and treating pain, especially chronic pain, has been going through a lot of whiplash turns, and you're no longer sure what to believe? Have you even discharged some of your pain patients feeling you're unable to assess and treat them fairly? Have you perhaps even decided not to take on patients with intractable pain anymore, even though they need primary care, and they've probably been looking for it, given our physician shortage, for a while now? And how about this? Do you wish KTEL would just make a painometer that would diagnose pain at a glance, diagnose its severity and its cause, and tell you how best to manage it? If any of that sounds familiar at all to you, then our podcast today is for you. Today we're talking about assessing pain. So have a listen, GPs and pain consultants as well. Today I'm joined by two physicians who care a great deal about the role of primary care in pain management and have new suggestions for evaluating pain. Alan Kaplan is a family physician in Ontario's York region. He's also a pain consultant and a clinical lecturer at the University of Toronto. Robert Hauptman is a pain consultant practicing in Edmonton. Dr. Hauptman is an assistant clinical professor with the Department of Family Medicine at the University of Alberta. He's also one of the founding members of the Pain Society of Alberta and the Alberta Medical Association's Chronic Pain Section. Dr. Kaplan, Dr. Hauptman, thanks for joining us.
Thanks for having us, Dawn.
Hey, Dawn.
Let me start with you, Dr. Kaplan, since I know you care deeply about this subject. What's the role of primary care in assessing pain?
So the primary care doctor, the family doctor, the nurse practitioner, in terms of managing chronic pain, first has to assess the patient. And I think what's really important is going back to the beginning. And the beginning is what's the cause of the pain, if you can figure that out, and having a good differential diagnosis. Not just assuming this is a pain that has no treatment, first making sure that there's not something that can be treated to alleviate the cause of the pain in the first place. From there, treatment can be treated, and then at this point, try to assess what kind of pain we're talking about. Is it a neuropathic pain, a nociceptive pain, or some kind of combination of that? Looking at them, you can start thinking about options. But before that, first you have to evaluate really how the pain is affecting the patient. Not just the pain itself, but how the pain is causing suffering, and what function assessments can be done to look at how the patient's managing with their pain. How has the pain changed their life? On top of that, you have to measure the patient's psychiatric comorbidities, the conditions they have that might make pain a problem for them in ways other than just the physical pain. With that, once we've looked at the pain, the function, we then want to assess the type of patient that we have in front of us, and is this a patient who is a high-risk or low-risk patient to be considering medications that have an addiction risk, such as opioids, benzodiazepines, gabapentinoids, etc. And then the last step is really to decide between the patient and the clinician what the goals of the treatment are. That's a bit of a long answer, I know, but really that's the basis. If you don't have all these things checked off, then you're going to run into trouble with your pain patient.
Okay, that's great. I was going to ask you about the basics of assessment, but I think you've covered it there. Let me ask you about the possibility that family physicians will get stumped. I mean, how do they, after all, evaluate pain when it's essentially subjective? There aren't any tests that can show it, that can diagnose it. Nobody knows if one patient's pain is worse than another's. With this subjectivity element in reporting by the patient, and given that there are no objective tests to evaluate pain, what does the physician do?
That's a wonderful question, Dawn. I don't think there's probably any other question I get asked more when I present to physicians then how do we deal with the subjectivity of pain? So I've given this a lot of thought. And the more you think about it, the more you realize that medicine is a very subjective science. So when somebody comes in with depression, there's no depression blood test. There's no depression imaging study. It is entirely the patient reporting to you their symptoms and you making some degree of an evaluation. Now, granted, there are scales and there are questionnaires, but even those are subjective. And this is virtually anything you can think of. Cough. There's no cough blood test. There is no cough x-ray. Again, the evaluation of cough is a subjective reporting by the patient. So when it comes to pain, we have to really listen to our patients and be willing to accept what our patients tell us. Now, the first step with that is often the classic numerical pain scale, the 0 to 10 scale that we use. And that scale sometimes can be misleading. This idea that, physicians get, well, geez, how can a patient with chronic pain come into my office and say they have 9 out of 10 pain when they're sitting in front of me and they look perfectly comfortable? And I think the problem there is missing out on what the patient's really telling us. So in acute pain, very quickly, the 0 to 10 scale really reflects pain intensity. When somebody comes in after breaking their arm and you ask them what their pain is from 0 to 10 and they tell you it's 9 or 8, that is an intensity score. Chronic pain, on the other hand, when you ask a patient what's their pain from 0 to 10, it probably, in my experience and many clinicians, more reflects their suffering. So I like thinking of it as a suffering score. So somebody comes in and they say they have 9 out of 10 pain. In my mind, that patient is suffering a lot. And I think this is really important for family physicians to know. So even if they're sitting in front of you and looking perfectly comfortable, when they say they have 9 out of 10 pain, they are really transferring to you, or we're trying to get you to understand this pain is really affecting me significantly. It's causing a great deal of suffering.
Can I just interject and ask? We touched on this in a previous podcast, but I think it's worth laying it out again. For you, Dr. Hauptman, what is the difference between pain and suffering? Lots of people would say they're the same thing.
Well, I think that pain in itself is in a sense, an intensity and an emotion, where pain is what primary suffering is what that pain does to you. So if I step on a nail and it goes through my foot, there's a pain intensity that I can say to my wife or the emergency room person who I see or the physician later on. It's very much that intense feeling you get when you get that tissue damage. However, if I now have pain 10 years later, well, now there are other things coming into play. There's where that sense of suffering, how that's affected me. And if it's still felt as very intense pain, now it may have affected my job. I may be dealing with insurance. I may be dealing with a spouse who is not as happy that I'm not working because I have this pain. I may be involved with physicians who don't believe me. I mean, now we're talking about a bigger bubble, and that bigger bubble, what that pain has caused in your life, that's what suffering is. And it's still very real. I mean, pain is real. Let's be very clear. So whether we think of it as an intensity or a suffering, the key here is not to invalidate the patient's reporting, and also not to put your own biases and prejudices into the evaluation. I see this all the time where patients will say to me, the doctor didn't believe me, or the doctor said I had back pain, it wasn't that bad, and so on and so forth. That's not the right way to approach this. We have to individualize patients and recognize their suffering as being truly their suffering.
In the primary care world, on top of that, and I agree with everything Rob said, I think it is important to measure something. And the measurement that we often use is something called the Brief Pain Interference Scale. And that's a scale that measures both pain and the visual analog scale from 0 to 10 that Rob has just mentioned, from the point of view of how bad it's been at the worst, how bad it is now, and so on. And it also gives you a Likert score out of 70 in terms of the ability to function because of the pain. While it's not really measuring suffering, it's measuring the functionability on top of the pain. And this also gives you an idea of where it hurts and what things have worked and what things have not worked. It's a very nice tool for the clinicians in the audience to use on a regular basis for the patients with pain to assess them. If you just ask, how are you, they're going to say it hurts. Say, how much does it hurt? They're going to say a lot. But if you actually get them to score it from time to time, you can actually get an idea of how things are different for them, which is also a really good way to assess whether your treatments have been helpful or not.
And for listeners who didn't catch that, we'll make sure that we put a link to this podcast to where they can get a copy of the Brief Pain Inventory tool.
Great. That's great, Dr. Hauptman. You said quite clearly, I was going to ask you both, how do you weigh what your patient says? Because you're quite right. We hear a lot that patients feel that their doctors don't take them seriously about the intensity of their pain and the extent of their dysfunction. So I was going to ask you, how do you weigh what your patient says? Dr. Hauptman, you said, I think, pretty clearly that you weigh it carefully, give it a lot of weight, that you try and keep your own confirmation bias out of it, that sort of thing. Dr. Kaplan, how do you feel? How do you weigh what the patient says about his pain?
Well, I don't want to repeat what Rob said too much, but I think what's important to recognize is the pain is a subjective feeling, and we cannot measure it. And it's also interesting that the personality behind the pain, the experiences of the patient with the pain, how the pain is affecting the patient's life, all those things are going to affect the suffering they have from the pain and the cost of this pain to that patient. So two people can have the same injury, but how someone deals with that pain or how that pain has changed their life. If you used to be a baseball pitcher, now you can no longer throw a ball, that's going to be a lot different than if your job used to be an accountant, and if you can't lift your shoulder up, that doesn't really matter because you only use a pen. I mean, these are that's silly examples, but it really is how the pain is affecting the person. And that's really the big picture. What is it doing to you, this pain? Not just a number out of 10, but what is it doing to you? What is it stopping you from doing in your life? What would you like to do still in your life? And can we realistically make those changes to your life to improve your quality of life with our treatments?
I think, Dawn, to add to that, I think it's important because to think about, again, an example I think most of us can get our head around, and that's obstetrics and women in labor. So if you take 100 women in labor, first-time labor, all roughly the same age, they're going to experience labor pain differently. That doesn't mean that we should treat somebody better if they're not having as much labor pain and somebody worse if they're having more labor pain. We recognize that individual nature of pain, and we deal with the patients before us. And I think the worst thing we can do as clinicians is start judging whether or not we really feel that the patient is pain. Some of that, to be fair, I think is come from pressure from insurance companies, maybe workers' compensation, where they want quote-unquote objective tests. Some of that, may come from just this view that we might have this bias that everyone's out to scam us and they're just after medications. And yes, there are people that may do that, but it's infinitesimally small compared to the amount of people who are coming to us looking for help for their pain.
Here's a question for you that occurs to me just as I'm listening to you both. You both seem what I would call progressive on this issue. How did you two come to be progressive on this issue when we know that there are a substantial number of clinicians out there who are ready to disparage patients in pain, particularly chronic pain? How did you guys get to be different?
Well, I think, not to pat ourselves on the back, but let's be honest. Treating pain, evaluating pain is difficult. And it takes effort. It takes ongoing learning, which hopefully these podcasts are providing. And it takes compassion. And to be fair, sometimes you do get burned, sometimes by people that you're trying to help. But if you remember, why you got into medicine in the first place, a lot of that is to treat people where they're at and to relieve suffering, to help people to live with sometimes some incredibly difficult illnesses, not only chronic pain, but we see a lot of complex illnesses can really affect a person's quality of life. Think of multiple sclerosis, bad COPD, bad diabetes. So I think, we've done a lot in this space, so that's probably why we're willing to look at it this way. What we want to encourage primary care physicians and pain consultants alike to do is to get excited about this population again, to say, hey, this is a group that we want to help, we can help, empower them to be able to help these people with knowledge, and then I think you'll get away from this jaded feeling that many of our colleagues may have.
And I can add to that a little bit, Dawn,
Sure.
in that it was basically the need that got me involved in this. Being a family doctor means you see everything, and what I was seeing was there was an awful lot of patients who had pain who were not having a good quality of life because of that pain. And what I needed was some kind of way to understand how to evaluate people like this and how to help them. At the end of the day, you see people because they want help. That's why we're physicians. So what had to happen was understanding the clear issues that we have to look at in terms of assessing the patient with pain. All the things I talked about. What the pain come from? What can we do about it? What kind of pain is so we can decide what kind of treatments we're going to have. Measuring the right patients to treat with the right medications. And understanding all the comorbidities that occur for the patient with pain so that we can get the right treatment tailored to the right person, etc. So for me, it was a situation where there was just such overwhelming need in my practice and in my community that once I could develop an assessment and understanding of how to do it, it became easier to do so and became easy to advise my colleagues on how to do so.
Wow, that's great to hear. Maybe we should clone you both, or at least make everybody listen to this podcast several times. I know that there are. We've discussed traditional ways that physicians evaluate pain. We've discussed pain scales and the likes, and their pluses and minuses, and we've discussed patient self-reporting. What about newer methods? I know you, Dr. Hauptman, you know quite a lot about this, and probably you do too, Dr. Kaplan. Whoever wants to throw in some info here, please do. I want to know about imaging, biomarkers, that sort of thing. Are they effective? Are these methods of evaluating pain, chronic pain, safe?
Evaluating pain in terms of using things like imaging tests and biomarkers are really at its infancy. It's exciting work. It's really interesting work. I'm not sure practically where we're going to go with this, because when we have a test, we have to make sure it's cost effective. But in research settings, we can evaluate pain. Functional MRIs, we mentioned in a previous podcast, clearly demonstrate differences between healthy patients, healthy controls, and a variety of pain syndromes like chronic back pain, like fibromyalgia. We know the structure and function of the brain changes through these types of imaging tests. We do, though, going back, not specifically just to chronic pain, but sometimes we do need to use imaging and laboratory evaluations to look for things that might be treatable when somebody presents with us to us with pain. So, for example, if somebody comes in over the age of 50 with a lot of stiffness, maybe affecting their pelvic girdle, their shoulder girdle, maybe some pain as well, we may not go to fibromyalgia initially. We may want to do a sedimentation rate to look for something called polymyalgia rheumatica. That's a disease we don't want to forget about. If we have somebody who's 60 years old who develops new onset back pain, who smoked for 40 years, we need to be looking for potential cancer causes for their pain, so we may need to do a back x-ray. So we still, in our evaluation, need to use some of the laboratory evaluation and the imaging studies. But when it comes to chronic pain specifically, these things in terms of biomarkers and functional MRI studies are still at this point more of interest to researchers than they are for clinicians, to be honest.
My 2 cents on this would be the following, that you image to make a diagnosis. You do biomarkers to make a diagnosis. The diagnosis is made, once it's made of chronic pain, which is a condition that requires treatment differently, then we approach it a little bit differently. And one of the dangers that I'd like to mention to our colleagues listening to this is don't keep investigating once you come up with a firm diagnosis. But doctor, shouldn't I do another MRI? You've had 6. Doctor, shouldn't I do another X-ray? You've had 100. There's no point. It's actually been clearly shown in the literature that by continuing to do tests on people where they're looking for that answer and that cure actually deteriorates their long-term care in terms of how they do short-term and long-term and prognostically. So the key thing here is image to make a firm diagnosis. Be comfortable. You've done everything you can to make sure that back pain isn't an abdominal aortic aneurysm in the case that Rob gave as an example, for instance. So that's the kind of thing we're trying to do. From there, we do not have imaging for chronic pain yet available in primary care in Canada.
So you're advising caution when we do, but I'm just curious, does either of you think that there's a fabulous future in imaging and in new ways to evaluate pain that might also help physicians treat it better? I mean, it's a speculative question. I'm just throwing it out there because I'm wondering what you think.
Sure. Yeah, it is, but, there are many, I do not want clinicians to feel that we have to come up with an objective test for pain before we can accept pain. I don't want, because that's not what we want to do. We want physicians to be empowered to believe their patients and to do a proper pain assessment. We don't need a functional MRI to diagnose pain any more than we need a functional MRI to diagnose depression. We can see depression on functional MRIs. We know it changes structure and function, but we don't need that. When a person comes to our office with depression, we believe them and we treat it. Likewise, when a patient comes to our office with a pain disorder, we need to believe them and manage that pain.
That's terrific. The analogies that you have been using just, I find, makes everything very clear. Hadn't thought of things like how there is not objective tests for things like depression and other kinds of illnesses. I think that really clarifies things. We really shouldn't treat pain as differently as we tend to, I think. Let me just ask you finally, what about factors that can complicate an assessment for a primary care physician? You mentioned at the outset of this podcast looking for psychiatric comorbidities. I think you did, Dr. Hauptman. What about things, maybe you could say a bit more about that, also about considering differential diagnoses. Another couple of things that occur to me that might complicate an assessment are patient attitudes. And also, we have to, I guess, talk about a little more than we have. We have to talk about the possibility of addiction risk in a patient coming to a clinician with chronic pain or even just with acute pain. So can you talk about that?
Well, you sort of answered your own question, but let me go through them. The assessment includes all of those factors, especially as we decide how we're going to treat. So, first of all, of course, is the pain itself and the comorbidities the person has. So, for instance, someone who has a sciatica, if they've also got diabetes, we don't know whether the sciatica is coming from their back or coming from a nerve injury from their diabetes. So the comorbidities they have will make a difference to the diagnosis. The comorbidities may also make a difference to the treatment. Certain medications that might be sedating might not be a good idea for someone who has a condition where they're already on sedatives or have a sedating condition, as a quick example. The next thing is how the attitude of the patient, and that's a huge issue, and that really requires quite a bit of work with the clinician and the patient, because the approach to the illness and how they deal with their illness is very important. Psychiatric comorbidities are very important because what I often say is if you are physically in pain but emotionally in pain as well, that's a pretty bad combination as a synergistic effect on bad outcomes. So we really want to be able to make sure that, first of all, the psychiatric illness isn't a part of the diagnosis of the pain, but that's not the big issue most of the time. The bigger issue is that pain then affects the psychiatric issues they have and makes it much more difficult for the patient to move forward and move positively through the treatment steps that we talked about before: exercise, psychological treatments, interventional treatments, physical treatments, religious treatments, and so on. And then lastly, as we assess our patients, what's really important is to make sure we're treating the patient with the right medication for the right person. And unfortunately, we do have patients who have a risk of developing addiction, especially from medications like opioids. But in fact, we're learning now it's not just opioids. It includes the gabapentinoids. It includes benzodiazepines. It includes a variety of medications that are sedating and therefore relieve some of those anxieties and so on that people have. And we use something called the opioid risk tool, which for the audience, we can also link at the end of the podcast as a tool that is a very interesting way to measure the risk of addiction in your patient being assessed. And it looks at, of course, things like their personal use of medications, substances, their family history of misuse of substances and medications, any risk of past sexual abuse, and any psychiatric illness. And, of course, younger patients are higher risk than older patients with this, unfortunately. So when you put all those things together, you get an idea of what's the risk of this person going on to misuse a medication that has the risk of addiction. And unfortunately, the difference between depression and pain is, because we use it as an analogy, is most people don't abuse their antidepressants. But some of them would abuse their benzodiazepines they use for their anxieties, as an example. So I think you have to have this thought with many medications we use because of those risks. But I think just to summarize, it's patient attitude, patient comorbidities, patient psychiatric state, patient's goals of illness, and unfortunately we have to also be thinking about addiction risk and make sure that we don't contribute to that problem. But I think the last statement on this is that we actually don't cause as much addiction as seems to be touted out there by certain people right now. But right now the world is saying that opioid deaths and overdoses are all due to treatments given by physicians. Well, that isn't the case. Most opioid deaths that are happening right now and addictions are happening in patients that have a disease called addiction, and they're misusing substances on the street in the way of fentanyl and carfentanil, and that's why, unfortunately, they're dying. It's not happening because clinicians are way overusing the medication. I think we have to be a bit more prudent, but we also have to make sure we treat patients' pain.
Right. I think that we've talked about this a bit in a previous podcast. I think Dr. Hauptman had made the point that addiction risk is really, really, really low. It's something like, I take the position that it's something like less than 0.5%. There are studies that show that it's a little higher than that, but it's not nearly as high as is often reported. So important to screen for, but not enough to close down treatment or assessment for. Dr. Hauptman, I don't know if you wanted to add anything to that last question. I just have one little follow-up to it that I'll throw at both of you, but I'll come back to you in case you wanted to add anything about the factors that complicate an assessment.
Yeah. No, I think the only thing to be clear, particularly in addiction assessment, because it is so important in this space, although I would argue in general, primary care physicians should be comfortable with assessing people for addiction risk, because I think we're missing a lot of potential other things that they could be addicted to, alcohol, cigarettes, gambling. I mean, there's quite a broad range of patients that primary care physicians will see that have substance issues. But I think there is an important point we need to emphasize at this stage, and that is just because you're at high risk for substance abuse doesn't mean you're going to abuse a medication. And likewise, just because you're at low risk doesn't mean you're going to abuse a medication. So although we might stratify initially in our assessment patients into either a low or moderate or high risk and initially treat those people differently, we have to be careful going forward that if a low-risk patient starts doing what we would call aberrant behaviors, maybe frequently lost prescriptions or lots of early releases, for example, we need to be aware that that person may be entering into some problematic behavior. Likewise, if we have a high-risk person we initially assess who is dead on all the time with their medications, they have never had any problematic behaviors, their urine drug testing is always normal, we may actually be able to soften some of the prescribing around that patient.
Excellent. This wasn't the follow-up that I was going to ask, so I still have a follow-up after this. This just comes out of what you were just saying, Dr. Hauptman. Addiction risk, how familiar are family physicians with the factors that constitute addiction risk? I mean, is there training on this in med school, in hospitals? How do they know?
Well, I think this is a problem, Dawn. You rightly bring this up. I think, again, it's probably the second most common question we get asked, Dr. Kaplan and myself, when we're presenting programs, is how do you do this? Because there isn't a lot of training, and we can't leave this just to our gut feeling. patient looks, they're professional and they look like they're not an addict. They're not going to be an addict. Likewise, if somebody comes with tattoos from their toes to their neck, doesn't mean that they're necessarily going to run into problems with addictive behavior. So we have to give family physicians, again, the tools. There are tools out there. None of them are perfect. The standard we talked about mostly in Canada is the opioid risk tool. That's a simple tool. And I will say it's not perfect, but at least it's the point of starting. And I think, we definitely are going to, have that tool and a link to this podcast so that family physicians can take a look at this tool and hopefully implement it in their practice. It takes no longer than a couple of minutes to do the tool, and it does give a lot of useful information.
Great.
It'd be interesting for clinicians to think about this risk early on. So, chronic pain, we've talked about in defining when it starts at 3 months or when it lasts longer, but maybe at the very first prescription for an opioid, even in a post-operative setting, you consider, is this a patient I should be more careful about the number I give post-op? There's now become a whole bunch of arbitrary rules given about how many tablets you can get to somebody post-op. And I understand why those concerns have been made and why these recommendations have been made. There's no basis in them being accurate. No one's ever studied them. I think what's more important is for the clinician to know their patient and to say, wait a minute, is this someone who's got a lot of psychiatric comorbidity with past abuse, who might fall into the habit of using this medication to alleviate psychiatric pain or psychological pain rather than physical pain and therefore get dependent on it? That's the kind of concern we would have versus someone who would never want to take a medicine unless the pain was so bad they couldn't function, that we'd have no concern about them ever misusing the medication. This is the thought process, my clinician colleagues, I hope you start having as you're thinking about this. Which are the patients I should be careful about? And start evaluating early for this, not late, not well after you started the medicine.
That's great advice. Thanks. Just one more small question coming out of this larger question of the factors complicating pain assessment. Dr. Hauptman, you had been speaking about psychiatric comorbidities and at the same time talking about patient attitudes and how these can complicate your journey through pain, your recovery, if you're going to have a recovery, that sort of thing. For me, psychiatric comorbidities and patient attitudes intersect. Insofar as I have heard pain patients say, and I have read I've read pain patients reporting that they are fearful to disclose to their physicians what their emotional state is about their pain because they don't want to be pegged as having a depression that needs to be treated. They just want to say, this is a sad situation for me. It has the potential to change a lot of things in my life. It already has changed a lot of things in my life. I'm sad about that. I'm not sure what to do about that. Those are the sorts of things that they want to say, but many of them apparently feel afraid to say that because they feel that they're going to be slotted as a possible risk for treatment. What can we do about that?
Well, the stigmatization of pain patients is clearly one of the consequences of this current opioid crisis that I think was predictable, but one that's often ignored. And I appreciate this. I appreciate pain patients who feel neglected and not believed, not wanting to admit to some of the mental health struggles that they have. I think if we can go back to this whole podcast about, being compassionate, listening to our patients, understanding our patients, validating our patients, saying, we're here to help you, and being more warm and welcoming, offering them hope, making them feel that they can talk to us about these things and they're not going to be, you're in pain because you're just depressed, or you're in pain just because you have post-traumatic stress disorder, or you're in pain because you have borderline personality disorder, for example. I think we've got to get beyond patients saying that we're going to label them and put them into these little boxes, and that really what we're trying to do as pain clinicians and primary care physicians is to treat the whole person. And unless we get all the assessment done right and understand all the things that are going on, we're going to fail to properly manage this patient. So we have to get across to the patient, we need all the information. If we don't have all the information, we're not going to be able to do proper management.
in order to evaluate the effect of the pain, we have to look at the things like the mood and the anxieties it causes. And every chronic condition will have effect on someone's mood. So using tools like a PHQ-9 and a GAD-7, which are tools for depression and anxiety, can really help you measure that. And even just help the conversation. So when these scores are very high, it's very easy for me to then turn and say, well, you've marked these scores as very high, so tell me how you're coping with this illness, and is there anything else going on? I think, once again, if we don't understand that that's part of the problem, we can't treat part of the problem. And from the clinician's point of view, from the patient's point of view, it's one more thing that we have to work on together in order to make someone feel better in the big picture. How you deal with an illness, whether it's pain or COPD, is really part of the illness and the management. And the last statement I'll make on this is the concept of hope that Rob just alluded to. And it's just quite incredible to me the number of patients I've seen over the years who the sole thing I've done different than the clinician who referred it to me is tell them, here is your problem, and here's what we're going to do for you, and here's what you're going to do for yourself, and we are definitely going to help this problem. We may not cure it, but we're going to help you. And someone who has had no hope to get better and now has hope to get better, that's the whole story, and that helps them move forward. But from the point of view of just the mood issues being afraid to mention it, well, if you don't tell me a problem, I don't know it's there. So if you've got chronic pain in your back, but don't mention the fact that you're also short of breath, then how am I going to diagnose your concomitant coronary artery disease if you've left that part out? A silly example, perhaps, but a situation that both Rob and I have seen in clinical scenarios. So the whole patient's management and give them hope so we can move on to a better future for them.
Not silly at all. It just makes things very clear for someone like me. These analogies work well. You should keep using them because in a way they reduce things to the simplicity that is behind them that we don't always see. Dr. Kaplan, Dr. Hauptman, this was very enlightening, all of it. I think we probably know by now pretty much everything there is to know about assessing pain as we understand it in 2018 at least. When it comes to how exactly to treat chronic pain, Drs. Kaplan and Hauptman will be with us again next time to give that topic a shot. So please join us again then. I'm Dawn Rae Downton. Hope to see you next time.
Thank you for listening. If you like this episode and want to hear more, please visit www.MDBriefCase.com and subscribe to the Get Brief podcast channel. Tune in next time for another exciting episode.